Welcome to Neurology, Disease Deep Dive. In this series, Dr. Derek Robertson, Director of the Multiple Sclerosis Division at the University of Southern Florida, and from the New York University Grossman School of Medicine Comprehensive MS Care Center, discusses multiple aspects of NMOSD. Dr. Robertson is talking with us today on behalf of Horizon Therapeutics, which is compensating him for his services and is sponsoring this podcast. In this episode, Dr. Robertson presents an overview of NMOSD and important considerations for diagnosis.
I'm here today with Dr. Robertson, and we're going to talk about NMOSD. I'm Wendy Terry, publisher of Practical Neurology. And how about if we get started, Dr. Robertson?
Looking forward to it, Wendy. Let's go.
Perfect. So the first thing I want to ask you is, we know that NMOSD is a B-cell driven disease. Can you explain the fundamental disease mechanism of NMOSD?
That's definitely a great kind of set the stage question as we kind of unpack the disease state of NMOSD is on a kind of zoomed in immunologic level. Why is it happening? So the B cells throughout their life cycle divide, and in a subset of them can become pathologic. And what we've learned about the disease of NMOSD is that we don't know the cause yet of why it happens, but likely the very next thing that happens, or very early in the disease process, maybe the better way to framework that is that a subset of B cells become dysfunction, pathogenic, and then start triggering the actual long-term inflammation that can result from the immune dysfunction.
Perfect. And do we have any idea of what causes that initial dysfunction with the B cells?
Yeah, so I would say broadly for primary central nervous system demyelinating disease, and there's kind of three big ones that we talk about that have overlap. And then as we kind of go, we can kind of start to distinguish between, but multiple sclerosis by far and away is the most common primary autoimmune central nervous system disease. NMOSD is a distant second, but shares some commonality with clinical presentations. And then MOG-associated disease is probably the newest of our understanding in the medical literature. But of those three, we have no clear defining mechanism that triggers them. And so NMOSD, I think we've probably made the most advances on knowing kind of why it happens to continue in patients. And we'll talk in a bit about aquaporin 4 and its contribution to the disease. But we don't know what triggers the individual person to develop the condition.
It's a great segue into our next question, which is, considering NMOSD is a B-cell driven disease, can you compare and contrast that to the other disease states that you just mentioned, like multiple sclerosis?
So there is clear overlap. I think that's fair to say. I myself, not too unrecently, have misdiagnosed a patient that I can think of that as having MS when they in fact had NMOSD. And it's because there is commonality to clinical presentation. There are some pretty distinct differences. So all three of them seem to have B-cell derived pathology, but they can be incredibly different. So MS, multiple sclerosis, is largely thought to be a B-cell driven disease in its classical form, the relapsing remitting disease. It's often a much more mild to moderate inflammatory condition, with patients by and large having a chance for good recovery after attacks. And that shares some commonality with MOG-associated disease. Again, also a demyelinating disease, perhaps maybe not as B-cell driven. There's at least some growing data in the medical literature that the B cells maybe don't drive a significant portion of the pathology. And in fact, some patients don't respond to B-cell depleting medications as well in that condition, but they can. And then lastly, NMOSD. So NMOSD is probably of the three the most classically B-cell driven, and its response to treatment supports that when we think about B-cell depleting medications historically that have been used, and then now more here currently with FDA approved treatment targeting B-cell pathology.
So what are astrocytes and aquaporin for?
Great question. So this actually gets to the heart of the disease process that happens with NMOSD, is that it's a predominantly astrocytopathy type of disease. And what we mean by that. So B cells are making autoreactive antibodies that are activated against aquaporin 4. Aquaporin 4 is not a bad thing. Aquaporin 4 is found predominantly in areas within the central nervous system that have high concentrations of astrocytes. Aquaporin 4 are found on the foot processes of astrocytes. Astrocytes being a glial cell, they're found inside the central nervous system. They often are lining either ventricles, or they help create the blood-brain barrier where blood vessels interface against central nervous system tissue. So not surprisingly, in areas of the brain and spinal cord that have high concentrations of astrocytes are where we can see them be prone to dysfunction and attack from patients that have NMOSD. So if NMOSD patients are churning out these angry activated autoreactive antibodies against aquaporin 4, and then they gain access through the blood-brain barrier to the central nervous system, well, in those areas that have high concentrations of astrocytes, therefore aquaporin 4, you can get attacks. So things like the optic nerve. The optic nerve has lots and lots of astrocytes, so you can get optic neuritis. Along the spinal cord, particularly along the central canal, lots and lots of astrocytes, lots of aquaporin 4. That's an attack area for NMOSD. In the brainstem, there's lots of areas, including area postrema, which is in the back part of the medulla, a common area where NMOSD patients can get attacked, and then a few others. But that's the role that they play, is that they're the end target, and therefore they could swell and die from attack of those autoreactive B cells.
We're going to talk now about what the key signs and symptoms are of NMOSD. So can you talk a little bit about what those signs and symptoms are and how you actually go about identifying the disease?
Great question. So when I'm teaching our medical students or our resident physicians or our fellow in kind of how to differentiate primary central nervous system autoimmune disease versus, say, secondary causes, I think understanding that there's overlap is absolutely okay, but there are clear branch point differences between certain diseases, and NMOSD, thankfully, is among the easier, once we kind of learn them, of kind of typical signs and symptoms and core clinical characteristics that really distinguish it from other central nervous system autoimmune diseases. What does that look like? So by far and away, the two most common clinical presentations, so signs and symptoms that patients will have, are transverse myelitis and optic neuritis. So about 95, maybe a little higher, 95+% of patients will have either one or both of those conditions at clinical presentation. Typical transverse myelitis symptoms, but huge. These patients can get longitudinally extensive transverse myelitis, which means it's a much more destructive pathology. So it's not uncommon for them to have quadriparesis with bowel and bladder involvement early on, lots of sensory disturbance into the arms and legs. Typical transverse myelitis symptoms, but very, very pronounced transverse myelitis symptoms that perhaps in some retrospective studies is in the neighborhood of about half of the patients present, about 50% present with that. Optic neuritis is about a third of patients, and there's some distinguishing clinical characteristics for optic neuritis. So it's much more likely to either be bilateral, including sometimes involving the optic chiasm. And so patients can get not just unilateral symptoms, that can happen. So just one eye can be affected, but it's actually a little bit more likely to be bilateral. And when you look on, say, neuroimaging, when you do MRIs, you're working these patients up, there's some distinguishing characteristics on MRI when you look to see, does it involve the back part of the optic neuritis, so the posterior division, and then the optic chiasm. That should make us think more NMOSD, perhaps even MOG-associated disease. Those are some ones that kind of tilt it towards that. Those are kind of the presenting ones. There's 4 other clinical syndromes that can happen, but they are a distant 3rd, 4th, 5th, and 6th, because there are 6 core clinical characteristics, but they're incredibly less common.
I'm thinking back to the comment you made just a few minutes ago about having a patient and you misdiagnosed them. It was actually you diagnosed them with MS and they had NMOSD. So is there an official framework for diagnosis for NMOSD patients?
There is, and it's what we still currently operate under. So about 8 years ago, there was a 2015 international diagnostic criteria for NMOSD, and it helped kind of lay the framework between distinguishing seropositive, and seropositive means positive for the aquaporin 4, AQP4 antibodies. And there's commercially available tests that are widely available to help with diagnosing a patient with this condition. That's the seropositive pathway, and there's diagnostic criteria for it. But there is also a seronegative pathway. So somewhere in the neighborhood of 20 to 25% of patients don't have the presence of the aquaporin 4 antibody, but they have very similar clinical presentations, and so they fall under the same umbrella diagnosis. But we tend to focus a little bit more, I think, correctly on the aquaporin 4 positive patients, because it thankfully is the majority of patients. Again, somewhere probably 75 to 80% of patients are going to have positive antibodies for that AQP4, but the diagnostic criteria is the same between the two of them with some slight differences. So what that looks like is patients that are seropositive, so they have aquaporin 4, only have to have one core clinical characteristic of those 6 conditions I started to talk about. So optic neuritis, transverse myelitis, then there's 4 other conditions, area postrema syndrome being one of them. That's persistent nausea, vomiting, sometimes hiccups. The area postrema is found, again, on the back part of the medulla. Those patients can have aquaporin 4 positive antibodies and have clinical symptoms that localize to that part of the brainstem. So that's number 3. The 4th clinical characteristic is brainstem syndromes other than area postrema syndrome. Anywhere else in the brainstem where you get a atypical demyelinating disease that, say, maybe doesn't quite look like an MS lesion, that's where we start to think about something like NMOSD. And then there's 2 other core clinical characteristics. One is symptomatic narcolepsy syndrome, where there's involvement in the supratentorial region, often subcortically, and then more diffuse cerebral syndromes, where you can get kind of big, very atypical looking demyelinating lesions that are often bigger than what you would expect to see with a classical, say, MS lesion. That can happen often, again, periventricularly. So those are the kind of 6 core clinical characteristics. If you're seropositive, and you diagnose the patient, as long as they've had one of those core clinical syndromes and they're seropositive, they meet the diagnostic criteria. It's a higher bar when somebody's seronegative, as it should be, because we want to make sure to be as accurate as possible with the diagnosis. So patients have to have 2 of the core clinical characteristics. So they have to have had 2 attacks, with one of them being the 3 most common. Again, optic neuritis, transverse myelitis, area postrema syndrome's a distant third. Patients that have seronegative NMOSD have to have one of those 3 at least once, and then they could have any of the 6 a second time. And then that patient, you could comfortably diagnose the seronegative NMOSD and then utilize treatments that try to prevent future clinical attacks.
Great. So you've given us a great overview of what the clinical presentation of these patients are and how you use that in diagnosing NMOSD. Are there diagnostic tests specifically that you use in this process?
It's a great logical next question. So identifying core clinical symptoms is kind of the first part. The cheapest, most cost-effective thing we do as healthcare providers is take a good medical history and do a good examination for our patients. And then utilizing that, our suspicion should be, hey, maybe this person has MS. Hey, maybe this person has NMOSD. Hey, maybe this person has MOG-associated disease. And then we can kind of build our differential diagnosis there and start with a diagnostic algorithm. So what that looks like in our practice is starting with typically the least invasive things, MRI of brain, MRI of spinal cord, if the clinical symptoms necessitate it, either the cervical spine, the thoracic spine, sometimes both. So doing some good high quality neuroimaging. If there's a suspicion for something like NMOSD or MOG associated disease, there's thankfully commercially available labs to test for those antibodies. And so we frequently would do that if, say, a patient presented with optic neuritis. That is part of our diagnostic workup, is to utilize those serum studies, because those are distinct diseases, say from something like MS, which also can have optic neuritis as a clinical presentation. But the three diseases are different, and response to treatments long-term can be vastly different. And so if somebody has optic neuritis or transverse myelitis, we're often sending both of those serum tests for MOG antibodies or the NMO antibodies, which is what the aquaporin 4 test is.
And I just want to circle back a little bit again to that clinical presentation. For NMOSD patients, we know they can have mild, moderate, or severe attacks, right? Can you compare and contrast what those presentations look like?
Oh, that's a great question, because that definitely is a part of helping distinguish between the different diseases, is that amongst the three that I keep referencing, NMOSD patients often have the most severe attacks. And there's an underpinning of the immunology of the disease that makes that more likely. Destruction of the astrocyte, which is the hallmark, we think, of the disease of NMOSD, given its the immunologic drivers of it, B cell pathology, churning out those autoreactive aquaporin 4 antibodies, activating the complement cascade, damaging the astrocyte. That flow of the problem can create pretty destructive optic neuritis symptoms, where patients can become functionally blind even after their first attack. Similarly, transverse myelitis attacks, patients can often be left hemiparetic, sometimes quadriparetic after their first attack. So they're more likely to have severe attacks potentially at presentation, but mild to moderate attacks absolutely can happen. I've seen it in plenty of our patients. We follow dozens and dozens of patients that have NMOSD, and so it's, I think, right to learn to be incredibly worried about our patients that have that condition, because they can have severe attacks, but there is a very clear percent of patients that can have mild to moderate, which they're not going to have different symptoms necessarily. So again, optic neuritis, transverse myelitis, those four other ones that we just went over, those 6 clinical syndromes are still the driver of symptoms that patients have. They can just have milder versions of them. And ariopostrema in particular can be quite annoying when patients get it, with persistent hiccups and nausea, vomiting, but often it resolves. And if you can get it accurately diagnosed, using acute treatments, if you already have an established diagnosis of NMOSD in your patient, those patients often get better. And I would put it more in the mild to annoying category of an attack that is often receptive to treatment.
Yeah, and when you're seeing these patients, do you prep them on watching out for those mild attack symptoms so that you're better able to treat them? Or is it just, you said oftentimes it goes away on its own? Is it a wait and see?
We try not to let NMOSD patients take the wait and see approach, because of the ambiguousness of how aggressive the attacks can be, but they're not always. We try to err on the side of caution for our NMOSD patients, and they get, in our practice, right to the front of the line. So if an NMOSD patient kind of calls into our practice with a new neurologic anything, then they're immediately triaged by a nurse, not called back later on that day or the next day to check up on symptoms. Where that is more of the typical flow of an MS patient complaint, is that we triage kind of severity and then decide kind of, maybe we want to get some labs, maybe we want to get some MRI. That's different than an NMO patient. When an NMO patient or an NMOSD patient calls our practice with new symptoms, we often are overbooking them and doing a telehealth clinic visit later that day, or directing them to go to urgent care or the ER for kind of sooner evaluation, because of that risk of what we might be dealing with being something mild to moderate could be leaving them functionally blind the rest of their life, or leaving them functionally hemiparetic the rest of their life.
You've done a great job explaining what those mild to moderate, or as you say, mild to annoying symptoms are, but also severe attacks. I'm just curious if you have any examples from your own patients that you could share on how somebody presented and what it took to get the proper diagnosis and treatment.
Yeah, so the most common being again optic neuritis and transverse myelitis. That's what we've kind of keyed our nurses, our advanced practice providers in our practice, our physicians that see patients. Given that that's going to be 95% of patient presentations, both at start of disease and then future attacks, I think those ones are the right ones to key in on. I think it's fair to also educate to the rest, but since that's going to be a minority of cases, those are the ones we really try to kind of tease out on history provoking questions. And if there's any sign of new onset blurry vision, pain behind the eye, scotomas, so you can get these kind of loss of vision or obscurations of vision in only parts of the visual field. When patients are complaining of that, whether it's one eye, both eyes, and they have an established diagnosis of NMOSD, that person is directed to go straight to the ER. And then we do neuroimaging, we're triaging them in the ER, we're often admitting them to the hospital for acute treatment because they're trending towards a very clear optic neuritis diagnosis. Similarly, transverse myelitis symptoms, so long track signs of weakness, numbness and tingling in arms and legs, anything that involves sensory disturbances in the torso. Those are all worrisome signs, the beginnings of a transverse myelitis that can very quickly, over a couple of days or sometimes less, spiral into very significant spinal cord attacks, so transverse myelitis attacks. So those are the ones that we're kind of cluing in on, that we want to really try to decrease the amount of morbidity that can come from those attacks.
Excellent. And we've already talked about imaging, but is there anything else in MRI imaging that you would share about NMOSD, especially as we look at the difference between NMOSD and MS? Are there certain things you look for that distinguish, that you go, this is definitely NMOSD or this is definitely MS?
Yeah. So, I mean, I'll start with NMOSD and I'll recap a couple of things I've said to kind of keep it in this segment. Optic neuritis looks very classical for NMOSD when it involves the back part of the optic nerve, so the posterior division, and the optic chiasm. And we can often see that on thin slices of MRIs of the orbits, pre and post contrast. Usually you can pick that up if someone's having kind of dense clinical symptoms. You often can see that on MRI. You can see the correlate. For spinal cord imaging, when patients have NMOSD, you're much more likely to see T2 signal change, so inflammation in the central canal. So the topography of the spinal cord, if you flipped it sideways and you looked at it on axial imaging, you can often see longitudinally extensive transverse myelitis around the central canal. So in the middle of the spinal cord is much more common of an area to see NMOSD. And then I would say lastly is the area postrema syndrome. Since those are the three most common things we can see, area postrema syndrome is pretty typical, associated with NMOSD, and it's a very specific and neuroanatomical point. So when you look on the often sagittal T2 flare of the brain, you can pick up the area postrema having T2 signal change, again, back part of the medulla. If you look at it on cross section, you look on axial imaging, on regular T2 axial MRI, you can see often T2 signal change, again, back part of the medulla in the area postrema if the person's having clinical symptoms of the area postrema syndrome. Again, those are probably the easiest ones to funnel towards an NMOSD diagnosis. Different than, say, MS patients. MS patients often have anterior segment optic neuritis. So when you are having a patient that has optic neuritis symptoms, often, very, very often, I've never actually seen bilateral optic neuritis acutely in NMO patients. I've seen patients have sequential optic neuritis where it affects one eye, years later, maybe the other eye. But when you look on MRI, you're much more likely to see anterior division optic neuritis. And then for MS patients, they also can have transverse myelitis, but it's often short segment, usually less than one segment in the cervical or thoracic spine. It's often peripheral in location. So again, if you look on axial imaging, you're much more likely to see it in the posterior parts of the spinal cord, so in the dorsal columns or the lateral corticospinal tracts, so off to the periphery on the left or the right side. Again, different than NMOSD, which is much more likely to be in the middle. And then a distant third to all of that is MOG-associated disease, which we're still kind of learning about. and it's got the most nebulous of MRI findings, although there are some distinguishing ones. It is also, say, optic neuritis. Patients can have that with MOG-associated disease, much more likely to be posterior parts. It can also involve the optic chiasm. There's often more of a perineuritis, so kind of enhancement of the sheath, which is a somewhat distinguishing feature of MOG-associated disease. It also can affect the central canal and the spinal cord. So it's a little bit harder to tease out between NMOSD. You can get weird, kind of funky, big brain lesions, sometimes brain stem lesions. So it aligns closer with being a confounder for NMOSD presentations. So that's why you're often encouraged to test for them together when you're initially working up a patient and you're not sure which of the two diseases they might have. We thankfully have a serum test for both.
Thank you for that. And I think we'll round out this episode just with a brief discussion on biomarkers. So we know biomarkers have been around for a while now, but we're really seeing a lot of interest, especially at the major meetings. Can you talk a little bit about the current role of biomarkers in NMOSD?
Yeah, there's definitely a whole body of literature that's starting to grow, thankfully, to hopefully move us as a field to delivering more personalized or precision-based medicine. Lots of other fields in medicine are way further advanced than us, often immunology-based fields, so hematology, oncology, even to a lesser extent, rheumatology. They have these kind of growing diagnostic algorithms that can help them personalize approaches to individual patients that have individualized diseases. NMOSD is a perfect example of something that it can trend towards that, because aquaporin 4 antibodies, that blood test that helps us diagnose it, that's a biomarker. So it's a diagnostic biomarker that can rule in disease. Annoyingly, it doesn't seem to correlate with treatment response, meaning that if you can make those autoreactive antibodies disappear in future blood sampling, it doesn't mean that you've eradicated the disease fully. There's been some retrospective studies, even prospective studies, that have tried to see, is that a thing that we can trend as a field? And unfortunately, it's been mixed results. So it's probably the answer to that is no. But knowing that they exist, those aquaporin 4 antibodies can lead to more accurate diagnosis. So if somebody's seronegative, that is a kind of patient where I actually would encourage testing in the spinal fluid. I don't routinely tell our patients that they need to have spinal taps long term to help accurately improve their diagnosis. But this is, I think, a growing exception to that if you think a person clearly meets the diagnostic criteria, but they're seronegative, perhaps putting them through a spinal tap at least once, where you're looking for those autoreactive antibodies showing up in the spinal fluid. We don't start with that. I think it's fair. It's much more easier to get a blood test done. But that's the biomarker that we kind of know the most about, because it helped improve accuracy of diagnosis. It's a driver of disease. But it's not a treatment response biomarker. There's been a couple of others in the medical literature that are starting to kind of show some promise. So GFAP, so gliofibrillary astrocytic protein, is one that we know can shed as a part of the disease process. So as those astrocytes are dying, GFAP can kind of bleed out into the spinal fluid. So there is at least some data that shows that maybe as you improve GFAP levels, that it would make sense that you're not having as much astrocyte dying, so you're controlling the disease better. So that could be kind of a treatment response biomarker. The problem with that is that the best way to test that is in the spinal fluid. Not ideal. You have to put your patients through kind of serial lumbar punctures to assess that. There's been a whole host of others that are all trending towards that same process, that cytoskeleton proteins that are damaged in shed as a result of the inflammatory process. So things like NFL, again, tau, there's a few others, but the kind of a circular process, kind of their usefulness and monitoring, knowing kind of normative values over time in healthy control populations, huge confounder with biomarkers. So I think there's a trend in moving to understanding biomarkers in these autoimmune central nervous system conditions, but we are nowhere near solidifying kind of hardened diagnostic and treatment response algorithms, but more work to be done.
Yeah. And as you look forward with that biomarker work, what would your hope be when you're specifically thinking about diagnosing and treating these patients?
Yeah, so our hope would be is that we have easy, quick, and reproducible access to the aquaporin 4 test, so blood test. So point of care tests would be phenomenal. If we can continue as a field to not have to wait a week, 10 days for aquaporin 4 test results, that would be an absolute game changer for the care of our patients. As it stands right now, it often takes that length of time, even if you highly suspect it, for patients to convert and get the lab result. So point of care aquaporin 4 serum test would be huge to help us as clinicians. And then again, building on those treatment response biomarkers. So you diagnose a patient accurately, you get them on treatment, and you follow them clinically, and you hope that that's enough to show that you stabilize their disease. But response to treatment that is on a blood or even lesser extent serum or CSF response would be even better.
Excellent. Dr. Robertson, thank you for your time today. I'll look forward to talking with you again soon about monitoring patients with NMOSD and what exactly that disease activity looks like. Thank you.
Excellent.
Thank you to Dr. Derek Robertson for sharing his knowledge with our listeners in this episode of Neurology Disease Deep Dive. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the neurology field. Neurology Disease Deep Dive is brought to you by the editors of Practical Neurology and sponsored by Horizon Therapeutics.